Okay, class. So we're going to start off with the chapters for Module 4. And the first chapter is chapter 57, Coordinating Care for Patients with Stomach Disorders. Also, keep in mind that I placed an announcement that also includes a downloadable version of the PowerPoint slides from these chapters from the course textbook. And I also reminded everyone about the associated ATI chapters for these topics. So if you get into chapter 57, you'll notice that some of this is just anatomy and physiology. So as always, make sure to review your anatomy and physiology as it relates to any topic that we discuss. So it just goes through some of the microscopic anatomy of the stomach wall and what role that plays, because that does impact conditions such as gastritis. And gastritis is a common type of condition that is often associated with the overuse of NSAIDs. So, a lot of patients who present with gastritis are patients that are ingesting NSAIDs on an empty stomach. And that's why it's so important that you educate patients that if they are taking NSAIDs, that they need to take NSAIDs with food. Because if you take NSAIDs such as ibuprofen without food, the question is not, will you get a GI bleed? It's more of when. Also, gastritis can be caused from the ingestion of irritating foods, such as spicy foods, pathogens, and stress. Remember the specific type of ulcer that's associated with being a stress ulcer with ICU patients. And that would be called a Curling's ulcer. And as we mentioned, that's why patients, one of the reasons patients would have proton pump inhibitors or H2 antagonists prescribed if they are admitted to the ICU is to prevent Curling's ulcers. And also, as we mentioned, though, you would expect H2 antagonist or PPIs to be used to decrease the risk of reflux, which may lead to aspiration pneumonia with ventilated patients. So, gastritis again is caused by E. coli. NSAIDs, but there could be other things that could cause gastritis, including Crohn's disease, bile reflux, and even tuberculosis. And yes, there even can be extrapulmonary tuberculosis, which exists. And a lot of people only think about tuberculosis as being a lung disease, but it can affect other parts of your body as well. And of course, if a person has tuberculosis, they would test positive for acid fast bacilli. Gastritis manifestations include epigastric pain, nausea and vomiting, decreased appetite, and changes in color of stool, especially if the stool is turning black or tarry or melena. That's often a sign of an upper GI bleed. Also, if patients develop gastritis and they have significant blood or fluid loss, they can end up with signs and symptoms of hypovolemic shock, which could include symptoms such and findings such as pallor, tachycardia, and hypotension. So the medical management of gastritis is going to include diagnostic procedures such as a biopsy, such as upper GI X-ray series and urea breath testing. Now, the urea breath testing is specific for the detection of H. pylori. H. pylori is a bacterium that is highly associated with peptic ulcer disease. And if a patient does test positive for H. pylori, you would expect the patient to be placed on a short course of antibiotics as well as medications such as proton pump inhibitors or H2 antagonists. Whenever you're looking at any type of medical management, you also want to consider what is the gold standard. So, what is more or most reliable? So, if you had to look at this list we have in front of us, the biopsy, the upper GI X-ray series, and the urea breath testing, the biopsy is most definitive. And in most cases, a biopsy is most definitive because that's how it can be viewed under a microscope and you can have a definitive diagnosis of a condition. And we'll talk about liver problems later as well. And biopsies are always definitive with biopsies of the liver. So, again, going back to this, though, it's important that everyone realizes what their gold standards are. Because what happens on exams is that sometimes you have more than one right answer and you have to pick the best answer. And one of the problems that some of you are having is that you pick the right answer, but it's not the best answer. So, for example, a biopsy would be the gold standard, whereas an upper GI series would be more suggestive. So, really think about that. What are your gold standards? Even when it comes to other conditions and other types of diagnostics, such as if you've got an arterial line versus a cuff pressure, you know that the A line is the gold standard as long as it is appropriately zeroed. But it is important to think about those gold standards. So, getting back to gastritis, you want to make sure that you have supportive care for relieving clinical manifestations. And sometimes the healing may be spontaneous. Sometimes there's going to be orders such as keeping the patient nothing by mouth. And then when you do reintroduce food, it's usually going to be clear liquids, with the diet being advanced as tolerated. You also want to eliminate offending foods such as spicy foods and manage fluid and electrolytes. Now, it's important to go back and remember one of the basic concepts of fluid and electrolytes, that anytime you have fluid volume shifts, electrolyte imbalances ensue. And that's true for any condition, not just for gastritis. You also want to ensure that you include other members of the healthcare team, such as a nutritionist, dietitian, etc., to help patients be more educated about what types of food to avoid, which types of food would be best for them. Also, there can be surgical management, including a vagotomy or a gastrectomy. These types of surgical managements are relatively rare for gastritis because most of the time they can be managed medically. So, these are some of the considerations you would have under nursing management, like the assessment for epigastric pain. And remember where your stomach is located. Your stomach is actually not located right in the epigastric region, but it's located more on the left side. And that's why you auscultate the left side whenever you're inserting a nasogastric tube. But your esophagus runs down centrally, and then it kind of branches off to the left a little bit to your stomach. You want to assess for nausea and vomiting, assess for decreased appetite, weight loss, and changes in color of stool, because changes again in the color of stool can be consistent with bleeding, and that could be a cue. Also, you want to think about nursing diagnoses such as acute pain, anxiety, knowledge deficiency, and risk for deficient fluid volume. Sometimes the deficient fluid volume may be related to things like vomiting and diarrhea, but other times the fluid volume deficiency may be related to insufficient intake because the person may have a sense of discomfort when they're taking food in, or they could just have general malaise and not have the urge to take fluid in. So, nursing interventions would include vital signs. You would want to look for signs and symptoms of hypovolemia. And again, the hypovolemia can present by a patient being hypotensive and tachycardic, or the actual hypovolemia can be true hypovolemia with actually loss of blood volume. And remember that you do have some cases relative hypovolemia to where fluid is just not in the space that it should be in. Like in the case of third spacing, because let's say the person has gastritis to the point that they're malnourished and they have low albumin, which means they have low protein. You could have a loss of oncotic pressure, and the patient could be have what's called relative hypovolemia, to where they're truly do not have a loss of fluid overall, but the fluid is just not in the intravascular space where you want it. You also think about history of presenting signs and symptoms. So, things that are your normal types of suspects, such as heartburn, indigestion, nausea, vomiting, uh, dyspepsia may occur after the ingestion of certain foods or medications. And the medications, again, that you would be most concerned about are your NSAIDs or your salicylates, such as aspirin. There can also be a relationship between the ingestion of alcohol and gastritis, and that would be dependent on the type of alcohol that is ingested. The gastritis can also be caused by endotoxins from food poisoning that have an abrupt onset. So one of the things that I want you to think about, though, if is that if a person has gastritis and they have uh, let's say diarrhea from the ingestion of spoiled food or food poisoning. This is the type of condition that it's better to let it run its course. That it's never a good idea, for example, to give a patient an anti-diarrheal if they have diarrhea that is associated with a foodborne illness. It's best to let things flow, because if you give a patient like an anti-diarrheal, for example, if they have also associated gastritis, it's going to entrap those toxins, and it's going to turn what could be like a 48-hour event into maybe a 1 or 2 week event. You want to monitor intake and output, monitor serum electrolytes, and this all goes back to what we've already learned about the relationship between fluid volume status and electrolyte balances. So also you need to think about specific electrolytes which may be involved, such as potassium, because potassium is one of those electrolytes that are um, highly influenced by fluid volume shifts. Also, you want to think about the type of testing again for like H. pylori. Um, for the presence of H. pylori to detect for that condition, since that is a treatable condition, that is a common cause of gastritis and peptic ulcer disease. Okay, you also want to think about nursing interventions. Well, just let's go back here a little bit too, about the fact that if a person has a lot of vomitus, then they're losing acid, right? They're losing hydrochloric acid. But anytime that a person is losing acid, you would suspect hypokalemia because potassium itself is an acid. So when a person is in an alkalotic state, then that is sometimes associated with hypokalemia. And if a person's in an acidotic state, it's associated with hyperkalemia since potassium is an acid. So also make sure that the patient always reports hematoemesis anytime that they're throwing up or regurgitating bright red blood, because this could be a sign of other conditions. It could be not just bright red, but it could be coffee ground. And this is important because you want to prevent hemorrhagic shock, which is a type of hypovolemic shock. Want to take medications as prescribed. Just as an example, if a person has severe gastritis or peptic ulcer disease, it would be important for the patient to really time their medications appropriately. For example, if they're prescribed Carafate, that Carafate would need to be, it's important that the Carafate would need to be taken like at a minimum 30 minutes to an hour before meals and at hour of sleep, because the Carafate actually provides a coated film that helps protect the gastric mucosal lining. Again, avoid irritants. You would evaluate outcomes expecting a full recovery and recovery of appetite. And then it goes into gastroenteritis. And gastroenteritis is the type of condition that's truly associated with either bacteria through undercooked foods, unpasteurized milk, or parasites, or the ingestion of a virus. So some of the usual suspects include salmonella, as an example, with undercooked chicken, and other types of toxins that are associated with either undercooked food or unpasteurized milk, uncooked seafood, for example. So the pathophysiology includes increasing the fluid, which cannot be absorbed by treating the depletion of intracellular fluid, because depletion of intracellular fluid is a problem with the pathophysiology of gastroenteritis. And the dehydration and electrolyte loss also needs to be treated because these electrolyte losses can be problematic, especially as we've discussed in the past, like electrolytes such as potassium. But also even other types of electrolytes such as magnesium and calcium as well can often be problematic um, whenever you're talking about intracellular electrolytes. These are the clinical manifestations listed for gastroenteritis. I'm not going to read through all of those, but it basically includes signs and symptoms that you would expect with a person being hypovolemic, such as the decreased blood pressure, the increased heart rate sometimes, the abdominal distension, poor skin turgor. Also, for gastroenteritis, it is important that the patient has a stool culture. And viruses are often more common than bacteria in some cases with gastroenteritis. And that's why it's good to have a good history from the patient as it relates to recent travel. It's also good to have in your history when did the signs and symptoms start? And a lot of times patients will be able to pinpoint it to a certain meal that they had, for example. Also, the testing for E. coli and C. diff may be necessary as well, again, based on the patient's history, because C. diff exists whenever there's an atmosphere for C. diff to thrive. So, for example, when patients have low levels of acidity in their stomach, that is an environment that C. diff can thrive. And that's one of the reasons that proton pump inhibitors have been shown to increase the risk of C. diff because these PPIs reduce so much acid that it creates an atmosphere for C. diff to proliferate. Okay, also, there may be a need to test for um, different types of parasites. And that's one reason a stool culture may be done is for ova and parasites. And again, as it relates to ova and parasites, it is really important to have a good history, not only as it relates to where the patient has recently traveled, but if they have a history of consuming raw or undercooked foods. So you also want to think about the treatment being supportive treatment with rehydration. And rehydration is very important. And whenever you think about rehydration, you specifically think about the use of crystalloids, which are isotonic solutions, such as 0.9% normal saline. Also, antibiotics and you always remember that antibiotics are cultures are drawn before antibiotics are given, but you don't necessarily have to wait for the cultures to result uh, to start the antibiotics because sometimes patients can't wait 24 to 72 hours to start the antibiotic. Sometimes the usual suspects need to be treated, such as E. coli. And then sometimes broad spectrum antibiotics may need to be administered until the cultures result, and then the patient can receive narrow spectrum. Antiemetics may be needed as it relates to gastroenteritis. But again, you have to be careful about the use of antiemetics and the use of antidiarrheals because you could end up in a situation to where you are extending their illness by preventing the patient from being able to get the uh, the irritants or the infectious agents out of their system by either vomitus or diarrhea. Also, remember that anytime a patient has a lot of diarrhea, or vomitus, they're at risk for hypovolemia, but then sometimes patients who are at risk for nausea and vomiting, or they're having nausea and vomiting, they may be at a higher risk for aspiration as well, depending on the underlying functioning of the patient. Also, you want to make sure that you do realize that the clinical manifestations can vary as it relates to gastroenteritis. And you've got to also think about the age range of who you're dealing with. Just for an example, we know that older people have less reserve. We know that older people have less body water content. And it's a lot easier for an older person to become fluid volume depleted and very dehydrated and hypovolemic and in hypovolemic shock more than a younger person, because a younger person has more body water content and more of a reserve. So it's important that if you're answering questions like on NCLEX, that you really pay attention to the age of the individual, because the age of the individual is often important as it relates to determining these types of factors. Okay, as it relates to nursing diagnoses can range from acute pain, diarrhea, gastric motility dysfunction, which can contribute to the pain. So if you have an increase in gastric motility, that means you're going to have an increase in cramping, which is going to contribute to discomfort. So these are some of the vital signs that you may encounter, or some of the assessment findings, including vital signs, and it mentions some of the other findings you may see. A lot of older people may have perineal skin irritation from the diarrhea, especially if they're incontinent. But again, really pay attention to the electrolytes. Look at intake and output. And we know that output is a good sign of perfusion. Urine output is, but you also want to measure the output. For example, if they're having large amounts of vomitus or large amounts of watery diarrhea. You want to make sure that nursing interventions, really read through these. Again, I cannot emphasize enough that many questions on exams, including NCLEX, come from your nursing interventions. And the reason that a lot of questions come from nursing interventions is because NCLEX primarily uh, assesses the test taker, the exam taker's application of knowledge. So it's not so much about knowledge in many cases, it's more about how you apply the knowledge. So you can read through those nursing interventions that include, of course, good, proper hand hygiene, but also VTE prophylaxis. And if you think about it, patients who are dehydrated do have a higher risk of being in a hypercoagulable state because of the fact that they are dehydrated and their blood is going to be thicker or more vicious than normal blood. And this increases the possibility of clotting. As it relates to other nursing interventions, they have those listed. It's going to be important that dietary modifications take place. It's going to be important that the patient is educated about proper food preparation and preventative measures. And always remember when you're answering these types of questions that nurses never delegate education. Nurses never delegate assessment. As it relates to evaluating outcomes, you would expect the absence of diarrhea, nausea, and vomiting. So these would be expected findings in the evaluation phase. Also, it's really important that we all look at what are expected versus unexpected findings. And these expected versus unexpected findings are going to vary based on which phase of the nursing process we're in. And some students are continuing to have issues as it relates to being able to differentiate what are expected versus unexpected findings based on where you are in the nursing process when you're answering a question. Okay. In the evaluation phase, you would have expected findings as it relates to the treatment. And earlier in the process, you would have all of these unexpected findings, but you have to consider that they could be expected as it relates to the condition itself. So there's a matter of interpretation that has to take place and critical thinking that has to take place. Peptic ulcer disease. This should be a review for you all, but it includes damage to the gastric mucosa. And one of the leading causes of peptic ulcer disease is H. pylori. And again, if a patient has H. pylori, they need to be prescribed a short course of antibiotics along with the proton pump inhibitors, H2 antagonist. And depending on the situation, they may need to have the Carafate or protective coating to protect against further erosion. So this just goes into peptic ulcer disease and the different types of levels that a peptic ulcer disease can take, or different types of a deepness that a peptic ulcer disease can have as it relates to erosion. So you can see that the top line shows just erosion that's more superficial, but then the second box is deeper and the other box is really deep. And you can have instances to where you can have a peptic ulcer that penetrates the gastric wall. And this can create a very bad situation and can lead to conditions um, such as peritonitis in some cases. But a perforation of the gastric wall is a condition that is very serious as it relates to peptic ulcer disease. The clinical manifestation is going to depend on the ulcer, the location, the patient's age, and also many times if a person has a peptic ulcer, they're going to find that their condition is worsened by eating. So by eating, their condition is worsened. So The other thing is that you have to think about if the patient is having improvement with antacids. And if the patient is taking antacids, it's important to know what type of antacid they're taking. Is it for example, a calcium-based antacid, or is it like an aluminum-based antacid? Because we know about the relationship, for example, between potassium and phosphorus, and how that inverse relationship happens if patients take too much antacids. The other thing to keep in mind when it comes to antacids is that you want to make sure that you think about things like metabolic alkalosis with antacids. You want to also think about the relationship between taking antacids and taking other medications. So, as you should have learned in pharm, that you normally want to take an antacid like 2 hours before or 2 hours after an antibiotic, for example. But in general, it's not good practice to take antacids at the same time that you take other medications. The medical management and diagnosis is done through an upper endoscopy. And again, I need everyone to think about what these procedures are. So, some procedures are diagnostic, and then some procedures are therapeutic. As it relates to an upper endoscopy, it can be both diagnostic and therapeutic. It can be diagnostic in that cultures are taken and samples are taken and visualization is done, but then it can be therapeutic if there are treatments that can be done during the procedure, such as ablation of an area, such as an ulcer, or sometimes even certain types of like even stenting can take place like in the setting of a severe esophageal stricture, things like that. So think about, is the procedure therapeutic or diagnostic or both? Also think about how you would prepare a patient for these diagnostic procedures. Again, the peptic ulcer disease management would include the use of antacids. And again, think about again what type of antacid and when it should be given in relation to food and medications. So surgical management could happen within the endoscopic procedure, and that's one of the ways an endoscopy can be therapeutic. Also, the surgical management is usually reserved for ulcers that are non-healing and ulcers that are bleeding. And one of the things that I've always told students is that having an ulcer, like a peptic ulcer, is kind of like having a scab on your skin. If you have a scab on your skin, if you irritate it and pick at it, then it's never going to heal. An ulcer is kind of like a scab, except it's inside your body. And if you keep irritating the ulcer, it's never going to heal. So that's why it's important that medications are taken at the time they are prescribed, and that medications such as Carafate are used in the proper timing so that a person can still eat without irritating the scab, if you will, or ulcer. So this goes on to talk about different types of operations that can be done for duodenal and peptic ulcer disease. And you can read through this. I don't want to go into a deep dive, but they mentioned the different types of procedures like a vagotomy, um, the pyroleplasty, the gastrectomy, etc. Know that if a person does end up having a gastrectomy, that this could cause the patient to have the inability to absorb certain vitamins, such as vitamin B12, which requires an intrinsic factor. Also, keep in mind that the duodenal area and the area of your upper small intestines is where most vitamins and minerals are absorbed. So these are some complications listed as it relates to peptic ulcer disease. You can read through those. And again, if a person ends up with perforation, they could end up with peritonitis. If a person develops enough blockage, they could have an obstruction. If a person has episodes of where there is a decrease in blood supply to gastrointestinal tissue, they could end up with an infarction of the area. And remember to always associate infarction with injury, necrosis with death. Also, the nursing man, and that would be death of the tissue, and in some cases, death of the patient. But going back to peptic ulcer disease, it's important that a comprehensive physical exam is done to rule out signs and symptoms of that may be associated with other conditions. And then these are some of the nursing diagnoses listed, including risk for deficient fluid volume. So, nursing interventions, again, this is an important area that you would want to expect to do vital signs. You would be looking for signs and symptoms of hypovolemia, for example. Gastric pH, you expect the gastric pH to be low, but in the case of peptic ulcer disease, you would want the pH to be a little bit higher so that the atmosphere is not so acidic. Also, they mention other things like diet, complete blood count, blood cultures, weight. And again, daily weights are the best overall indicator of fluid volume status. So again, you would want to look at, is the patient taking NSAIDs? Do they ingest alcohol? All of those things too. BUN. Okay, and this is an example of how BUN is affected by other things other than kidney dysfunction. You have BUN and creatinine that are used to evaluate kidney function, and creatinine is the surrogate marker. The higher a person's creatinine, usually the worse the acute kidney injury. But with BUN can be impacted by other things other than kidney dysfunction, and that is why BUN is a lab to look at for kidney dysfunction, but BUN can be impacted by other conditions, including gastrointestinal bleeding. You would want to make sure to look at serum potassium. Again, if a person has a lot of vomitus, they're going to be losing acid. Therefore, they're going to be losing potassium because potassium is an acid. You want to also assess the patient about uh, aggravating versus relieving factors. And that gives you an idea as well as what types of food should be avoided. You also want to sometimes even do a 24-hour recall of diet to see, okay, how often is this patient eating? What types of food are they ingesting? What types of either eating or being, you know, uh, not eating impacts the pain level. The CBC is good to look at to evaluate hemoglobin and hematocrit. And the H&H may be low if the patient has GI bleeding, but remember the hematocrit may be elevated if the patient is hypovolemic. Not hypovolemic from bleeding, but hypovolemic from loss of water or fluid. And then the patient may need to have blood cultures of their peritoneal fluids. And sometimes these patients, depending on the organism, may need to have antibiotics or antifungals. And then in some cases, even antivirals. You want to make sure that uh, weights are done because weight and changes in weight could be indicative of even more serious conditions, especially if they have greater than a 10-pound loss in weight over a relatively brief period of time. These are the other nursing interventions like maintaining IV infusions. And again, if the person is at risk for hypovolemia and hypovolemic shock, they need to have at least one large bore IV. And a large bore IV is considered to be anything 18 gauge or larger. You want to make sure to be able to prepare them for an endoscopy, assist for any lavages, and to document and monitor pain and treat pain um, as necessary. So there's going to be a lot of teaching. And again, this will never be delegated as it relates to their medications, about avoiding eating within 2 hours of bedtime, and to avoid other risk factors. And so we all know that there's a lot of non-pharmacological risk factors as it relates to not just peptic ulcer disease, but GERD. For example, there's a relationship between gastroesophageal reflux disorder and GERD and a peptic ulcer disease. So even things like wearing tight-fitting clothing could be something that can contribute to GERD, therefore peptic ulcer disease. Also, you want to evaluate care, and you would expect these within normal limits findings like increased comfort and control of pain and toleration of diet um, following or during the evaluation phase. Gastric cancer is the second leading cause of cancer mortality worldwide. Gastric cancer usually begins as gastritis. And over a period of time, this dysplasia can lead to an adenocarcinoma. So, anytime that you have chronic irritation, that chronic irritation can lead to changes at the cellular level, which can lead to cancerous conditions. That's why in general, there is a high relationship between irritation to tissue, and the development of cancerous conditions. The 95% of gastric tumors are adenocarcinomas, and the one problem with adenocarcinomas of the stomach is that they can have early metastasis. So this goes into describe the different types of appearances of gastric cancers. You can read through those. This goes through the clinical manifestations of gastric cancers. A lot of times, these patients are not going to be symptomatic until later in the disease process. But a lot of these patients may have a palpable abdominal mass. They may have vague epigastric pain rather than being able to clearly describe their epigastric pain. But the one key thing is going to be the weight loss and anorexia. Those are really concerning findings that could be suggestive of gastric cancer. For gastric cancer, they're going to be diagnosed with a barium x-ray, endoscopy, and cytology. And remember that whenever you have um, some of these tests are going to be suggestive to where some are diagnostic. So like cytology to where they actually look at the cells are going to be diagnostic. So with gastric cancer, you would expect antiemetics to be administered and opioid analgesics to be administered. And with the treatment of gastric cancer, chemotherapy and radiation alone are not going to be effective. These patients are going to require gastric resections, especially in early stage gastric cancer. Again, gastric cancer is high risk for metastasizing early on. Some of the complications they can have are listed, but one is dumping syndrome. Remember that dumping syndrome is rapid gastric emptying. And dumping syndrome is a condition that can lead to malabsorption of nutrients, but also dumping syndrome can lead to severe diarrhea. Um, Also, if a person has a gastrectomy, they're not only going to be at risk of dumping syndrome, but they could be at risk for peritonitis because they can have leakage at the anastomosis. And of course, an anastomosis is where you link two areas of tissue together. You relink them together after a part of the tissue or organ has been resected. They're going to be at high risk for strictures and internal bleeding. But again, dumping syndrome or rapid gastric emptying is going to be one of the most common complications after a gastrectomy. Okay. And again, you have to know that early in the disease process, there are not many clinical manifestations, but later you're going to have a plethora of clinical manifestations. And again, it's likely to metastasize early. These are some nursing diagnoses that are listed, including imbalanced nutrition, less than body requirements, but also other things like anxiety and fear. There's going to need to be a number of different assessments that take place, including assessing for signs of metastasis. So you would want to assess for any lymph node involvement because as you have probably learned, the lymph system is a super highway. It is a super highway to where the good guys can get on it, like the chemical mediators that are released, and anti-inflammatory types of chemicals are released too, and the white blood cells can get to different areas, but the same superhighway of the lymph system is the same route that the bad guys can take, such as cancerous cells. And that is how a lot of cells travel and metastasize from one area of the body to another, is through the lymph system. So whenever you are looking for their lymph node assessment, you're assessing their lymph nodes. The types of lymph nodes that are concerning are your lymph nodes that are hard, non-tender, immovable, and irregularly shaped or textured. So you would rather find a lymph node that is tender than a lymph node that is hard and non-tender. So make sure to go back through your lymph node assessment. And then it's got other things that you may see as anomalies in your assessment. And they have listed bilirubin, alkaline phosphatase, and that could be related to metastasis to the liver. You could have a an abnormal oral glucose tolerance test that could be a confirmation of dumping syndrome. Also, it goes into the assessments of, looking at the location, characteristics, onset, duration of pain, the location of pain, characteristics of pain, frequency, quality, intensity, and any precipitating factors. Look for early signs of dumping syndrome, including vertigo, tachycardia, syncope, sweating, pallor, and palpitations. Also, there's a need for teaching as it relates to consume small, frequent meals, and also to have that anticipatory guidance as it relates to, is the condition curative, or is what you're going through palliative care? Because in some cases, you do have procedures that are more palliative than curative, especially in the setting of having gastric cancer, which has widely metastasized. They go into some additional teaching as it relates to medications, as it relates to what types of foods to ingest. You would expect these patients to take in high calorie, high protein diets. A lot of these patients are going to need nutritional supplements. A lot of these patients are going to need to be guided by a nutritionist. And again, to be able to recognize signs of dumping syndrome and to have a good idea of what types of foods they can tolerate. Some foods are going to be more likely to induce dumping syndrome than others. And that is it for this chapter. Make sure to look through the case studies at the end of each chapter PowerPoint slides, and make sure to that you're doing those dynamic quiz questions, that you're taking you're answering questions on a daily and weekly basis. And the next chapter will go through, I will post that after posting this chapter, which is chapter 57. Again, make sure to read through those ATI associated chapters as well.